Okay, thank you. So presentation today is about environmental carbon monoxide exposure during pregnancy. I might just give a weeny bit of background to this so you know how we came to this area of work. And this has become a real priority area for us. And it came through actually us implementing an approach which includes measuring exhaled breath CO in pregnancy to identify and support pregnant women who smoked to take that risk from their pregnancy. And we then realised that actually some of that CO we were seeing in those exhaled breaths were not from smoking, they were from other sources. And my interest and involvement has grown significantly from there. This project, and I'd like to start off by saying thank you so much, was funded by CORT, and it was given to us to support the development of protocols and pathways for the identification of those who are in danger of harm with appropriate treatment pathways. It's in two parts. The first part was a review of the literature around what we know about the harm, how best to identify pregnant women who are at risk of harm, and to understand how we should treat those pregnant women to protect them, but particularly it's the protection of their unborn children, and to look for knowledge gaps. Do we have all the knowledge we need to actually move forward into action, or do we need further research? The second part was presenting that literature review to a group of experts. And when I say experts, across quite a wide field in carbon monoxide, but also in pregnancy, and actually also around smoking, and experts who are experts in the academic world, in the public health world, and in the clinical world in the NHS in the UK. And the roundtable gave us an opportunity to discuss our findings and to identify those gaps, and to start to think about who can fill those gaps and what we needed to do next. The first part of this was undertaken actually not by me personally, but by Beth Cheshire working with us, an academic colleague who did a very detailed review of the evidence. And I had a quick look before I came on about who's on the call, and I know there'll be a mixed knowledge about environmental carbon monoxide. So just to remind ourselves, it decreases the ability for O2 to carry O2 in the blood, and that decreased oxygen supply impacts tissues and organs and causes hypoxia, hence our concerns. Symptoms are various and partly depend on the seriousness and the level of carbon monoxide in the system. And if anybody is on here from that works with pregnant women, and we'll come back to this, you will know that headaches, fatigue, nausea, feeling weak, bit dizzy, not the loss of consciousness, thank goodness, at that end, but those first few are not just symptoms of CO poisoning, they're quite often symptoms of pregnancy, particularly in the early days of pregnancy. And these symptoms correlate with the level in the blood. So it's from those headaches and symptoms, headaches maybe even asymptomatic at 10%, through to a likelihood of death over 60%. We've all got a baseline. We've all got some CO in there. And generally for non-smokers, it will be less than 2%. And for smokers, it will be greater than 5%. And the causes for being above that level in a healthy individual are complex. But one of the key areas is around those who smoke And in the UK, it's exhaled breath CO is used as a way of identifying smokers, but also in working with them to show the reduction in harm as they move away from tobacco use. But generally, heavy smokers, you'll see raised levels as high as 13%. And we'll come back to this because there's the complexity of a raised CO can be caused by more than one thing. So you could actually be being exposed to high levels of environmental CO, but also your CO could be raised because you're a smoker. So this is not an easy area. Who's most susceptible? Well, the high-risk groups are the very young, very old, people who've got pre-existing diseases, but the unborn baby. CO exposure is exceptionally impactful to the fetus. It crosses the placenta and binds with the fetal hemoglobin. CO is taken up by the fetus much slower than in the mother. So if you're looking at the pregnant woman's CO level, it won't it won't reflect the level within the fetus. Once the fetal levels begin to rise, they reach maternal levels and then continue to increase, surpassing those of the mother. And again, we'll come back to that in a moment. Acute exposure in a pregnant woman, you would see the levels rising rapidly and slowly diminishing. For the fetus, the levels would very slowly increase, reaching maternal levels at approximately 1.5 to 2 hours. Continue then to rise to twice the level of the mother. And during acute severe intoxication, the baby can actually die of anoxia due to the saturation levels. In chronic exposure, and this is an area we are really concerned about, again, maternal levels will rise rapidly in the first few hours and kind of gradually slowing, reaching plateaus in 7 to 8. Whereas for the fetus, the levels rise much more slowly and they won't reach that maternal level till about 14 to 24 hours afterwards. So there's a danger that we think, okay, so it's going down in the pregnant woman, we're past that danger period, forgetting or not knowing that for the fetus, that level is still going up. And the evidence shows that it'll continue to rise, kind of reaching that state of equilibrium around 36 to 48 hours later. So they are exposed for much longer at much higher levels. And the concentrations are about 15% above the maternal levels. For those of us who work with carbon monoxide, we talk about half-life. And in the pregnant woman, the half-life's around 2-3 hours, but for the fetus, it's around 7 hours. So what we're seeing in the mother is not representing what is happening in that fetus. What do the case reports show of the impact of acute maternal CO intoxication? Well, it shows more likely to be a preterm delivery, more likely to see hypoxic ischemic encephalopathy, seizures, cerebral palsy, and limb malformations, and potentially death. These are things we talk about a lot when we're talking about the potential impact of smoking in pregnancy. But we very rarely hear this talked about in maternity, midwifery and obstetric practice in terms of environmental carbon monoxide exposure. In the early stages, at an early gestational period, it's the anatomical malformations that happen, same as we say for smoking. But later stages are more likely to cause encephalopathy and neurological sequelae. And that's due to the vulnerability of fetal brain to CO closer to full term. And we know a little bit about those critical levels as well, about where actually that severe poisoning may end up for the baby in intrauterine death. So summarise that part. Fetus is extremely vulnerable to CO. Chronic exposure can cause disproportionate harm. Fetal outcomes of CO poisoning is difficult. It's limited what we know, and we know a lot more around perhaps smoking than we do around from environmental work. But great concern because of those poor fetal outcomes and the fact that low level exposure may in fact be extremely harmful to the fetus. So we don't have a really good way of identifying a fetus that is in significant danger. The chronic exposure kind of links us into that low level exposure, and the research here and the understanding is limited, but we know that chronic exposure to low level CO is of particular concern to for the fetus. It's extremely hard to diagnose. The symptoms, as I said earlier, may be symptoms that can be put down to other causes in pregnancy, and particularly in early pregnancy. It's unlikely that environmental CO will be suspected as a cause of the nausea, headache, tiredness. I know if I'm working with pregnant women, my question will be, are there other people in the household that feel like this? And do you feel better when you're out of the house than when you're in the house? Are there particular times of the day when you feel more like this, to give me an indicator? But that is not something that our midwifery colleagues are systematically taught to do at the moment. So big possibility of misdiagnosis, particularly if the woman smokes. There will be a presumption often that all of that CO is because it's coming from the pregnant woman's use of tobacco. So maternal smoking, we know the risks are well identified of fetal growth restriction, prematurity, stillbirth and miscarriage, long-term impact, including behavioural problems. And this is being addressed and has been being addressed in the UK for a long time, and is one of the focuses of the long-term plan for the NHS in the UK, and maternity services are now actually putting in place their own in-house stop smoking support to enable women to get very prompt and evidence-based support. And the evidence shows that birth weight, for instance, is significantly lower in infants, even at 6 to 10 parts per million, as measured in the pregnant woman. Let's move on. Exposure to air pollution in pregnancy. There is evidence, more broadly than CO. There's some evidence of potential detrimental effects from chronic exposure, low-level exposure. And they include the same things we're talking about: intrauterine growth retardation, low birth weight, and premature birth. And that can happen at really fairly low levels of parts per million of CO, particularly during the later pregnancy in the last trimester. Exposure in the home to air pollution during pregnancy, again, limited, but there have been studies showing associations between maternal exposure and stillbirth and low birth weight, and extensive amount of evidence indicating that biomass smoke exposure during pregnancy can increase the risk of low birth weight. But in relation to CO specifically, there are a few studies examining, only a few studies examining air pollution exposure during pregnancy. So evidence indicates this is an area of concern because of how CO can contribute to adverse fetal and infant outcomes. And we should remember here, it's really important that it's not just what happens, the impact when that baby's in utero, but it's the lifelong impact from what happens in utero. That impact, that low birth weight, just when they get their birth weight, when they get their weight back postpartum, it's that risk has not gone. They may live with the impact of that CO throughout their lives. So for me, this is about us finding a way of ensuring we give every baby the best start in life. And given that these findings represent a significant risk, it's in order to give that best start, it's an area that we should be addressing, I think, more than we are at the moment. What do we know about how many unborn babies may be impacted? Well, we've got the information from, just more generically, about homes in the UK, indoor and exposure from indoor sources. 326 homes monitored in one study, 19% had levels exceeding an 8-hour guideline of 9 parts per million. And they were kind of frequently associated with things like gas appliances. And in the UK, that's not just about boilers and about how we heat our homes, but it's also about how we cook, because many cookers, at least all or partially, use gas in the UK. And my thoughts are, we're not seeing it here, but my thoughts are that those who are more vulnerable in our society and less able to protect themselves are likely to be more exposed than others. CO exposure in the home during pregnancy, we know little about, and Adrian's just mentioned the study that we're actually undertaking at the moment. And in fact, we're just waiting in the next week or so to open our winter monitoring that we will be doing as part of that research in pregnant women's homes. The only way we have at the moment is by if somebody recognises the symptoms, if a professional recognises the symptoms, or the family recognises the symptoms during pregnancy, or when the woman has an antenatal appointment, that the levels are seen as suspicious. They want to find the cause, and they think it may be environmental. Problem with that is, by the time a woman arrives at the maternity unit, she will have been out of her home for some considerable period of time, and therefore the levels will have dropped and maybe have gone back to a level that would not cause questioning by maternity and obstetric care staff. And also, if they smoke cigarettes, then the likelihood is that any increased reading will be put down to smoking. So in the UK, 9.6% of pregnant women at the moment smoke during pregnancy. This is going down, and we've had quite significant success, but it's still far too high. We've got nice guidance from 2010 and more from 2020, which says that pregnant women should be routinely tested for carbon monoxide at antenatal appointments, and women are tested to identify those who smoke. And they're not asked if they want help. They are actually told that they will be referred for treatment to help them get rid of that risk. But it's only smoking where there is a referral pathway to reduce the risk of carbon monoxide. Reynolds in 2019 looked at a group of 234 women who were monitored in pregnancy, and 23% had a breath CO reading of above 3 parts per million, but only 15% were identified as smokers. Women who reported as non-smokers that had a breath CO level that was high were categorised as non-disclosers. My suggestion would be that there may be a significant number of those that could have CO exposure for other reasons. And if those interventions are done well, it helps women who do smoke to have an honest conversation with their midwife about their smoking behaviour. And my midwifery colleagues are extremely good at doing that, having those conversations. So I would be very concerned about how many of those that did not disclose they were a smoker actually were exposed in the homes, and that we weren't offering treatment to them, which would be very different treatment pathway than for the smoker. Also, for the women who are smokers, as I said earlier, not necessarily all from tobacco. We know in England that the women who are more likely to smoke are likely to be young and living in poverty. And again, they are most likely the ones that are least able to protect themselves from the impact of environmental CO. Do they get the boiler service regularly? Do they feel able to ask the landlord to address issues of safety around appliances in the home? Have they got a CO alarm? And we'll come back to the CO alarms. But, the raised CO levels observed in up to 12% of pregnant women who report to be non-smokers may be related to CO exposure. That's a significant risk for our pregnant population. And NICE guidance says something about what maternity staff should do with that, but it's more focused on non-smokers than smokers. And also there is no adequate training for midwifery and obstetric staff to feel skilled in identifying that risk, and also in knowing, other than asking the woman to ring the emergency gas line, to know what to do about it. So key concerns. I'm conscious of time. We haven't got the training in place that we should have for our professionals working with pregnant women. We don't routinely provide what I would consider adequate information to pregnant women and their families to help them protect themselves. There's not the clarity about parts per million or symptoms that should instigate women down a particular pathway to help protect them. We haven't got those pathways and protocols and algorithms in place to help our professionals know when that support needs to be put in place and what that support is. That we may be totally under-identifying women at risk because of the half-life of exhaled CO, and that most women's CO is done outside the home. Going back to the training, we might not be able to, our professionals may not be adequately trained to be able to identify them. And we're labelling people with, to some extent, with high COs as non-disclosing smokers, and not, I don't think, having enough focus on what could be the other causes. Non-smokers, in some areas, we found were being referred to stop smoking services. I'm not sure how that would help the relationship with the midwife. It says, I don't believe you. And also, are they likely to turn up because they know they don't smoke? And therefore, they're going to get even less help because midwife will think they've referred them to somebody who might know a bit more about CO, but they won't turn up. The only place I know that this is being discussed is in the Smoking and Pregnancy Challenge group, because it came out of the issue around smoking and pregnancy. There's a question to whether that's the right place for this to be dealt with. Many pregnant women in England will go through their pregnancy without health professionals seeing them in their home. So we don't get that opportunity to actually find what the levels are like when they are at home. Pregnancy is not at the moment officially a factor which would allow registration on the Priority Services Register in England. So which would allow them access to more help. CO alarms don't help identify chronic low-level poisoning. Most of these levels we're talking about in the low-level and chronic would never set a CO alarm off. And we're hearing a lot from pregnant women and professionals that they feel that having a CO alarm makes them safe. And it makes them safe from the impact of severe acute poisoning. But it could leave them feeling safe for any CO, and they're not. So they may have been exposed to 10, 15, 20 parts per million for months, but not have any recognition that that's happening. If a baby is exposed in utero, unless we intervene, the likelihood is it will also be exposed after birth, so that harm will continue. And it could actually impact the ability to breastfeed, which in England is something that we're focused on helping increase in our population. There's a need to change the narrative about CO testing and why we're doing it. If we really mean we want to identify environmental CO, we need a woman-centered approach and a co-designed approach. We need to involve those who are most likely to be impacted in ensuring that they can engage in any intervention that we develop. We need urgently to get training to our midwifery and obstetric colleagues and other key professionals that helps them to identify those women and ensure that they have appropriate referrals. And we need to understand who's the most vulnerable. We need to make sure we've got pregnancy-specific information, and we need the pathways and protocols and algorithms in order that when a woman is identified as being impacted or as harm of being impacted, that the pathway is there to ensure they get the right treatment and we minimise the harm to her and her baby. There's certainly quite a lot of areas for further research. We need pregnant women on the priority services register. In our research, fire and rescue services are being amazing in going into women's homes and having those conversations as part of the research, but also offering what we call safe and well visits. And I think there's a real potential to look at how we can systemize that so we can ensure that all pregnant women have the potential of having that safe and well visit in their own home. We need to think about the levels at which alarms alert people, because at the moment we are falsely making people feel safe because they don't understand the dangers below the level that the alarm will sound. And we need to raise concerns with all the involved agencies to get them together to actually make some decisions about the actions that they can take to help us protect women. That's it. Thank you. Have I managed it within the time, Adrian?